Hello guys, hope you are all okay. You are all enjoying your life. You're also practicing ultrasound and you're also watching my videos. Welcome back to Dr. Arshad Nadeem Awan ultrasound teaching video. Today my topic of discussion is related to radiology and related to X-rays and procedure, that is hysterosalpingography or HSG. It is a very important test, diagnostic test to find out whether there is any blockage or scarring in the fallopian tube or within the uterus. So these are the reasons for the HSG. HSG is a very important procedure. By doing this procedure, you can diagnose and find out where the blockage is and where there is scarring. Sometimes these blockages and scarring may cause because of the pelvic inflammatory disease, because of certain infections, due to any fibroid, or due to Asherman syndrome. Asherman syndrome, as I mentioned earlier, that is actually adhesion within the uterine cavity which leads towards the infertility. So basically the patient will give you the history of infertility, and for the confirmation of this tubal blockage or scarring, you need to perform the HSG. So what are the best timing for the performing of the HSG? The best timing is 5 to 14, in between 5 to 14 days of your menstrual cycle. So within that time period you can perform the HSG, and the process of the HSG is to inject within the uterus through the catheter iodine. So because iodine is radiolucent, radio opaque, and we can easily pick all wherever this iodine is, and it will help us to identify any blockage or any problem. As far as this HSG importance is concerned, it is widely used for the diagnostic purpose, but beside this it has therapeutic purpose as well. By the time you're pushing iodine, it may take out any blockage if there is within the uterine cavity. So this is used for both purpose, for the diagnostic and for the therapeutic purpose as well. There may be multiple reasons for the blockages, and there will be multiple types of the blockages. Sometimes there will be unilateral blockage, sometimes there will be bilateral blockage, sometimes there will be partial blockage, sometimes there may be some other outer or external reasons for the causes, so for the blockages. So you can confirm all that on the hysterosalpingography. I have collected some of the images of the HSG, which shows the normal HSG, which also shows the primary blockage, secondary blockage, partial blockage, complete blockage. So all these information you will get on these videos. So let's start watching these images, and further on these images I will give you further narrations as well. So hopefully this will be a very useful video for you. So let's start watching these images. This is radio anatomy of HSG. HSG is hysterosalpingography. Hysterosalpingography, while you are performing hysterosalpingography, you need to have the iodine. Iodine has the property of radio opacity. It appears white on the rays, on the X-rays especially. So here the image will appear in this way. This is the HSG normal image. You can appreciate uterus, uterine architecture is clearly visible on this ultrasound. This is HSG on X-ray. Beside this, you can, if you focus on the right side, you can appreciate fallopian tube all the way down, having its infundibulum and its femoral up to the femoral end, and there at the end you can appreciate spilling of the dye, spilling of the contrast into the peritoneal cavity. So towards the right, all the fallopian tube is patent, it is clearly visible, there is no blockage can be seen, there is no external compression on the right side. So it means this is the right side normal fallopian tube with the spilling of contrast into the peritoneal cavity. Now focus on the left side. Left side fallopian tube is also patent. You can appreciate all its parts, its infundibulum, its end area, and beside this the spilling of contrast, spilling of dye can also be seen into the peritoneal cavity. So on that image you can see both right and the left fallopian tubes are patent. There is no external impression on that. There is no compression effects can be seen on either fallopian tubes. There is no blockage, so it's mean these both tubes are open up to its final end, and beside this there is spillage of contrast into the peritoneal cavity, which would be absorbed later on. So this is what a normal hysterosalpingography image you can document, and you can write about the uterine competency, about the fallopian tube patency, and also about the spilling of the contrast into the peritoneal cavity. This is another HSG X-ray, and this procedure is performed through the catheterization, by catheterization, and iodine is injected through the cervical canal into the uterus, and then further you can appreciate the right side fallopian tube is visible, the left side fallopian tube is also visible. Beside this, spilling of contrast can also be seen into the peritoneal cavity. So what is the difference between the previous X-ray and this X-ray? There is some difference which you need to take into account. That is preparation. Preparation it really very important, and it counts a lot. Look at this here. There is a lot of bowel gases, and it's mean that the bowel was not properly prepared. That's why a quality image cannot be achieved. So ask the patients to or put the patient on proper bowel preparation before doing that procedure. And as I mentioned that there is a time frame, like from 5 to 15 days of the menstruation, you better perform this HSG if you want to take the proper evidence of the fallopian tube and the ovary. So it will give you the clear picture. If the bowel is clear, and if the patient is prepared, and if the patient is in its proper menstrual time frame, and then the procedure is properly performed, so you can get a lot more information on the X-ray, on the procedure, and it will help your patient towards the management. This is another HSG. Here you can appreciate a lot of information on this HSG. Look at their speculum visible, which is used for to insert the cannula into the cervical canal, and for the injection of the iodine. So iodine is a contrast which is radiolucent, and that's why you can appreciate the integrity of the uterine cavity because of this radio opacity. You can appreciate on the both side these fallopian tubes are open, and spilling of contrast can also be seen into the peritoneal cavity. Some of the bony landmarks can be visible. You can see SI joint, both sided patent SI joint can be visible. This pubic bone can be seen, and these all areas can also be seen on this image. So therefore it is important that the patient should be properly prepared. So this patient was also properly prepared. That's why you are able to get all the related information regarding the fallopian tube, the uterus, and the surrounding area on this image. So this is a classical HSG image. So now start looking for the pathology. This is HSG, and on this HSG you can appreciate a uterus. Uterus is clearly visible because of the presence of iodine. It appears radio opaque, so integrity of the uterus can be easily seen. Both sided walls are clear. Up to the level of the fallopian tube entrance, the uterus can be easily seen. These both arrows pointing towards the starting of the fallopian tube. Afterward, there is no fallopian tube visible. It means that these fallopian tubes are either not properly opacified, or these are totally blocked. So there are two possibilities. The one possibility is bilateral blockage of fallopian tube. This is the first diagnosis. The second diagnosis is because of the spasm, sometime these fallopian tube get blocked and cannot be easily opacified. So that could be due to the muscular spasm. This would be the second diagnosis. So this is bilateral tubal blockages. This could have been due to any infection or could be due to Asherman syndrome, but the possibility of Asherman syndrome is not very likely because uterus is clearly visible. Asherman syndrome is a syndrome when there is adhesion within the uterine cavity. So if there would have any adhesion, this would have never been visualized. This could have you wouldn't be able to see the uterus in this proper position. So it's mean that Asherman syndrome is not there. This could have been due to any infection or maybe because of any external impression. If there would have any fibroid, it might press the fallopian tube, but the chances are very unlikely because it is seldom happens that on the bilateral side there is fibroid which is pressing on the fallopian tube. So this is another not the possibility. So it likely to be due to infection. So the important thing after this HSG is you straight away put the patient on the ultrasonography and look for further information. If there would have any fibroid, it would be easily picked on the ultrasound imaging. So therefore these HSG is to look for the tubal patency. In that case your report would be bilateral fallopian tube blockage. Look at the another spectrum of pathology. Here uterine cavity, uterus is clearly visible. On the right side you can appreciate the tube is fully patent, and you can also see the spilling of contrast into the peritoneal cavity. As far as the left side is concerned, on the left side there is no opacification of the fallopian tube. It means that the left side tube is blocked. So again this tube may be blocked because of the infection, or this tube may be blocked because of any other condition like maybe endometriosis, or maybe uterine fibroid is compressing that part, or maybe any abdominal surgery. So these are a few possibilities which may cause the blockage of the one-sided unilateral fallopian tube, that is towards the left side. So here on the left side you cannot see any evidence of the fallopian tube. This spelling of contrast is from the right side, and the right side fallopian tube is patent. There is no problem with the uterus. Uterus is also patent, uterus is also normal. This is unilateral blockage, unilateral, or you can particularly mention that the left side fallopian tube blockage. This is another HSG X-ray. On this X-ray you can see that uterus is fully patent, uterus is properly opacified. On the either side, on the right and the left, part of the fallopian tubes can be seen. So mean towards the right and towards the left, half of the fallopian tube can be visible. These are opacified, but the rest of the area you cannot appreciate on that. This is the one point. The second point is no spillage of contrast. It means that half of the tubes are blocked. So on the right side and on the left side, partially visualized fallopian tube suggestive of partial blockage of bilateral fallopian tube. So there, because there is no spillage of contrast, all the contrast is blocked within the fallopian tubes and the uterine cavity. So this is a partially blockage, bilateral partially blockage of the fallopian tube. So again it arises the possibilities of certain infections, some endometriosis, some fibroids, some previous abdominal surgeries, some previous adhesion. So these are all multiple factors you have to look for the causes of the partially blockage fallopian tube. So this is a classic example of partially blockage fallopian tubes. This is another HSG image, and here on that image you can appreciate that uterus is clearly visible. It is properly opacified. As far as bilateral fallopian tubes are concerned, these both tubes are properly opacified. You can see that contrast has been gone through all the way to the peritoneal cavity, and you can also appreciate the spilling of contrast into the peritoneal cavity. Here there is one important pathology is lying. You need to pick that pathology. What this pathology is really? That pathology is uterine fibroid. So have a look. That is towards the left side upper part of the cervical region. There is a hypodense, there is a lucent, radiolucent round image visible within the uterine cavity. This is fibroid. So mean on the HSG you can also pick the fibroid. Beside all the information, patency of the fallopian tubes can be seen, spilling of the contrast can also be seen. Otherwise normally uterus is visible normally, but the one pathology which you can pick on the HSG is fibroid. So this is radiolucent round shaped fibroid within the uterus, and especially in the area of the fundal. So the fundal fibroid can be picked on this HSG. This is another HSG image, and on this HSG image you can appreciate well defined uterus which is properly opacified, and both of these tubes are visible. Both of these tubes are patent. These are clearly visible. These are properly opacified, and you can also appreciate spilling of contrast into the peritoneal cavity. As you can properly see the uterus on this image, another important finding is fibroid. Fibroid sitting within the uterine cavity, and this fibroid is radiolucent. Surrounding areas are radio opaque, but this particular area where the fibroid is sitting has not taken the contrast, so that's why it's appear as a radiolucent. So this is a radiolucent fibroid. On your report must mention that uterus is normally opacified, and there is a small round radiolucent area can be seen, which is likely fibroid, and further correlation is recommended with the ultrasound imaging. As far as both tubes are concerned, both of these tubes can be seen patent and properly opacified, and spilling of contrast can be seen. So from the point of view of the patency of the fallopian tube, this HSG is normal. On the conclusion you just mentioned uterine fibroid, ultrasound pelvis is recommended to confirm the findings. This is another HSG image, and on this image you can appreciate properly uterus. This is properly opacified, and small area of uterus you can see it's appear as a radiolucent. So this radiolucency is because of the fibroid, and this fibroid is in the cervical area. So this is actually cervical fibroid. Now come to the right side of the fallopian tube. Right sided fallopian tube is normal. It is normally opacified. It means it is patent because the spilling of the contrast can be seen on that image. So it means the right sided fallopian tube is patent. Now concentrate on the left side. There is no opacification of the left sided fallopian tube. It means this fallopian tube is totally blocked. This is an example of complete blockage, but this is only unilateral. So unilateral blockage of fallopian tube, the left sided fallopian tube is completely blocked. So left sided fallopian tube is blocked, and right sided fallopian tube is patent. On the image you can appreciate fibroid. So in your conclusion you must mention this is unilateral blockage of the fallopian tube, and there is evidence of the cervical fibroid. Ultrasound is recommended for the further workup and for the confirmations of the uterine fibroid. Hysterosalpingography can also be used to pick the Mullerian duct dysgenesis or Mullerian duct anomalies. Here look at on this image on HSG. This is a classical example of a bicornuate uterus. Bicornuate uterus has two fundal portion. Here you can appreciate there are two fundal portions, each one has its own fallopian tube. However, the lower part of the uterus are joined together. They are joined by the both part, but the upper part, fundal region, is separated. So there you can find two fundus if you are examining that on the ultrasound, or if you are looking on the HSG. So on the HSG you can find V shape like here, two cervical two fundal region, but the cervical part and lower uterine body would be the same. On that image towards the left side you can see a fallopian tube, and to some extent there is spillage of the contrast. So it means the fallopian tube on the right side is blocked. So there is a blockage of right sided fallopian tube. The left side fallopian tube is patent. So in the conclusion you would mention that this is a Mullerian duct anomaly, congenital anomaly, and this is bicornuate uterus having its patent fallopian tube on the left side. Right sided fallopian tube is blocked. So this is unilateral fallopian tube blockage associated with congenital anomaly, that is bicornuate uterus. On this HSG you can appreciate one another congenital anomaly, and this congenital anomaly is called as uterine didelphys. This is an example of uterine didelphys. Here you can appreciate that there is two segment, like this uterus is aparted from each other until the level of cervical. So each part has its own fallopian tube, and you can appreciate right and left fallopian tubes are patent. Spilling of contrast can also be seen into the peritoneal cavity. As this uterus is aparted centrally and it causing two separate compartments, so therefore this patient will complain of infertility. There is quite difficult in conceiving pregnancy because of the less room available for the pregnancy, and second, abnormal anatomical position. So these type of congenital anomalies can also be picked on the HSG. Sometimes if a clinician is not expert in doing ultrasound, so they might miss all these finding, all the ultrasonography. They cannot easily pick these type of congenital abnormalities on the ultrasound imaging. So therefore if you have any confusion and you do not know that which type of a congenital anomaly is this, so better to go for the HSG. HSG is the reliable method which can project the uterine cavity and out its congenital anomalies, and you can easily pick these abnormalities on the HSG. On this hysterosalpingography, another congenital anomalies has been shown, like this is complete septated uterus. So complete septated uterus has further two division. This septa may be complete and this septa may be incomplete. So within the uterus the septums divide the uterine cavity into two compartments. Sometimes it contain fully septa until the level of cervix, and sometimes this septa remains within the endometrial cavity or remain confined into the endometrial cavity. So these two types of version of congenital anomaly you can appreciate. Here on this image, this is septated uterus, but this type of separation is complete separated uterine cavity. So this would be a completely septated congenital anomaly or completely septated uterus. In this type of congenital anomaly still there is infertility because they both have separated fallopian tube, and sometime they might get blocked on the either side, or they may be unilateral blockage. Whatever the case may be, it can be easily confirmed on the HSG. So therefore perform the HSG for the uterine abnormality, for the congenital uterine abnormalities, and for the fallopian tube blockage. Look at this image. This is again bicornuate uterus. You can appreciate that the cavity is split into two, and each side has its own fallopian tube. On the right side there is fallopian tube visible along with the opacification, and beside this you can also appreciate the spilling of the contrast into the peritoneal cavity. Fallopian tube on the left side has also been opacified So you can appreciate fallopian tube till the its lower end, and spilling of contrast can also be seen. So on this image, this is congenital anomaly, and you can easily pick on the HSG. So as I mentioned, this is bicornuate uterus, and in bicornuate uterus, small portion of a united lower uterine cavity can be seen, and afterward you can see that this part the cervix has been split into two, the uterine body has been split into two, and it's making them a particular position of bicornuate uterus. Bicornuate uterus can be easily picked on the ultrasound imaging. If you see once this bicornuate uterus on the ultrasound, you can easily pick it and you will never forget that. But on the HSG, as it is quite clear, just put the contrast in, and contrast will opacify all the area, and you can confirm the tubular patency on that, and also you can confirm the uterine abnormality or congenital abnormalities. Another slide, this is the best example of septated uterus, but this is complete septated uterus. Here on this uterus, towards the right side, you can appreciate opacified fallopian tube till the lower end, and beside this contrast has been expelled into the peritoneal cavity. So the right side is completely patent and it is normal. As far as the left side is concerned, still that part is part is completely normal and patent. As far as fallopian tube is concerned, you can appreciate small fallopian tube running towards the lateral side, and also you can appreciate some spilling of the contrast. So this is another congenital anomaly. As I mentioned that on the HSG, Mullerian duct dysgenesis can be easily picked. Before going to do any other radiological imaging, for example MRI or opting some other techniques, it is better to go for the HSG. HSG is the reliable method, and it picks all the point related to congenital anomalies of the uterus, and also confirms the fallopian tube patency, and also confirm its blockage. On this HSG, you will appreciate unicornuate uterus. This is a type of congenital anomaly which has its own rudimentary horns. Sometimes there is single rudimentary horn, or sometimes there is both rudimentary horn. There is a chance of having endometrium in one of the rudimentary horn having its own fallopian tube, so that would be an activated one. And if it is communicating with the main uterine body, so there will be no problem, and that would be a normal one, and it would be considered a normal one. But at times, in some of the cases, this rudimentary horn does not communicate with the main body. If it does not communicate with the main body, and it does not possess endometrial cavity or endometrial thickening, so it's mean that is fine because there is no endometrium. But if it has, or it possesses endometrial cavity, and yet it does not communicate with the main body, so the endometrial growth and endometrial secretion will start accumulating with the uterine cavity, and it with the particular that horn, and it will result into hydrometrocolpus, or sometimes it leads to another serious abnormalities. So therefore you must be very careful when you are performing these images. HSG is the only reliable method to confirm the congenital abnormalities and also confirm the tubal patency. Yes friend, this was all about hysterosalpingography. Hysterosalpingography is also called as HSG, and there were sufficient information has been provided to you to understand how you can confirm the partial blockage, complete blockage, and how you will pick the fibroid if there is any within the uterine cavity. So hopefully this would be a very useful video for you. Keep watching my videos, keep sharing my videos, and with some new topic we'll see each other. Till then, take great care of yourself. Bye bye.